look at me today. I'm the only person in jacket and tie, more or less. And that will be the last day in which you will see me in jacket and tie, because this is a very informal meeting, and this is what I like of this meeting. Finally, my presentation is focusing on the future. But we cannot make any presentation and any discussion about what will be the future if we don't think about the past and the present. Because indeed, the story of resistance is the story of HIV and any virus. So nothing new, even though something is changing. This is a paper that came up a couple of months ago that shows from the Swiss cohort, is a very peculiar cohort in which many Swiss patients are enrolled, and the characteristics of the patient are very peculiar, quite different than those that we have here in Italy, Spain, but perhaps very similar to those that are in German. And you see that the new, and again let me stress, the new detection of drug resistance is really marginal, both in terms of drug resistance and triple class resistance. While this was something that we were used to for many years, driven by the lack of real efficacy of the antiviral therapy. Today, with the new therapies and with the proper use of the antiviral therapy, now this is a situation. The detection of new resistance is very limited. And I think this is a result that I shared with Richard Harrigan in another occasion. And that is very common, I think, for many of us. Even though this is only one part of the story, or if we want one side of the coin, because these are the data that come from our cohort. These are patients that failed the therapy. You see that over the years there are about 10,000 patients. You see that the number of patients that failed the therapy in 2001, those that had a very limited resistance or no resistance, were really a minority. We are talking about 13%, while the large majority were 2 or 3 class resistance. Over time, thanks to the improvement of the therapy, the number of patients that failed without resistance is definitely increasing, while those that have a triple class, a dual class resistance, shrink. And then I think this is shared by many of us in Western Europe. May not be the same in other countries. I can tell you that in Africa is exactly the opposite. I do not present you anything about Africa or third world countries, but this number is definitely increasing. And about 95% of the patients that fail therapy in Africa do have multiple resistance. So this is a situation in Europe, in Western Europe, that is pretty common. But you can see certainly something that is interesting to be noted. From more or less 2010 and beyond, the number flattens. And the number of patients that fail without resistance is substantial, but flattens. And we have about 4% of patients that remain multi-drug resistance. They do not die anymore, at least they die far less than in the past, thanks to the therapy, to the rescue therapy. We have a dual class resistance that is pretty stable, a one-class resistance that is pretty stable. So in other words, my perception is that we reached the sort of plateau that is good in some way, because this means that these patients are alive, these patients are have the virus under substantial control, yet they are with us. So this is a typical patient that deals, that runs in our clinics. This is a patient with a long history of seropositivity and therapy. He started therapy with high viral load. A lot of therapies, I do not say anything about all the combination, but you see that nearly all drugs have been used in this kind of patient. And this is the story in 2014 with many mutations both in protease and in reverse transcriptase, not in integrase. Of course, raltegravir is given, and the only result that we achieve in this condition is just to generate resistance also to integrase. Then after raltegravir, dolutegravir is given with different combinations. In other words, this is a patient that is alive. His CD4 are still sufficient to let him survive. Viral load is in the range of 20,000, but you see that the large majority of the therapeutic options are lost. Last week, I was consulting for a very complex patient in California, very similar to this one. And the result was a combination of 3 attachment inhibitors. because there was not so much more to do. So, but the good news is that these patients are still alive. So they are with us, and they represent the upper part of the iceberg. In other words, those that have a viral load detectable, that have failed, still alive, that they represent only a small part of those patients that, thanks to the new therapies, we could control the virus a little bit better than in this patient. They have a controlled virus, still alive, fortunately, still with us. Nevertheless, of course, the virus is not under full control, so it might come again. So this is a conclusion that Joe Heron gave in his presentation at CROI. That was quite interesting. He gave a very nice presentation. I don't know how many of you were at CROI this year. And that was his conclusion. Resistant HIV will always be with us. That is not a pessimistic way. It's just a representation of the reality. That we have patients that do not have resistance, patients that never failed, patients that failed that are under control, patients that failed that are not under control. The latter two are a minority compared to the others, but still with us, and they use a lot of our energies, money, and drugs in order to care about them. So we need to really deal with that. So let me move from the last part of the story, that is a patient that failed therapy, to what that they will stay with us until 2020 and perhaps beyond that. So this is also our future. But let's see together what's the situation instead in patients that start therapy today. I think this is the data that Mariella, Domenico, and Danilo in our group have evaluated from our cohort. And I think we can share the idea that 90% of the patients starting first-line therapy have a virological suppression. This is more or less the result that come from our cohort. I think this is very common to what you see. About 97% of the patients reach, after 72 weeks, undetectability. Reach. Doesn't mean maintain. Reach. So that means that reaching undetectability is a necessary condition in order to have control of the virus, but it's not sufficient because that situation needs to be maintained. And you see that by exploding these different patients in those that have a different viral load at the beginning, you see that the story that virologists have ever said is still real. Those that have a very high viral load, particularly those with more than 500 copies, do reach undetectability later, less, even though still very, very, very good result. But what we obtain in those that have at the baseline very normal, very low viral load is quite different than in those patients. So we need to care a little bit more about these patients, essentially because we have in this patient an increased risk of failure with resistance. So, and this is a typical patient with a substantially high viral load. I'm not sure anymore that we can consider 100,000 as high viral load. I think for clinical practice, I think 500,000 is the real figure that expresses the real high viral load. Today, probably the patient that have a little bit more than 100,000, I'm not sure that we can call them high viral load. Probably needs to be considered carefully when we design clinical trials. And you see that this is a kind of patient that didn't reach undetectability, even though the result was pretty good. You see that this is a failure with about 100 copies, with some variability of the virus in the protease. So this led us to intensify the therapy with darunavir 600, and the result, you see. This is somewhat against the rules, because everyone says that intensification is useless. I think that we can most properly say that intensification is useless in the majority of patients, in particular in all those in which there is no evidence of replicative signs of the virus. When we do have some evidence that the virus replicates, perhaps intensification has a meaning. While it's true also the opposite. This is another patient that started therapy again with a relatively high viral load, but in particular with a resistant virus. And this patient was started a little bit with a therapy a little bit stronger than was supposed to be, and then simplified. And the result is pretty good after about 8 years of therapy. So the question is whether this kind of therapy would have been, this kind of result would have been achieved even in case we would have used the classical therapies since the beginning. We have no randomized clinical trial that give any evidence for that. We tend to use our clinical practice. So, and taking care about the resistance according to what we know since today. But as I said, the reaching undetectability is not the final result. It's the beginning of a story today. So we achieve undetectability in about 95% of the patients. We need to maintain, and you see that in the next 2 years after achieving undetectability, about 17%, that is 1 out of 6, tend to fail. And this failure is again exploded in different viral load at the beginning. You see that again, those that have a high viral load at the beginning, 500,000, do have an increased risk of failure. And this increased risk of failure probably needs to be considered carefully. This is a mostly virological meeting oriented to clinics. We need always to remember that the high viral load is not the cause of the disease, but is the effect. Because if the body is unable to control the virus, we have a viral load high. But if we reduce the viral load, that doesn't mean that we eliminated the causes that brought the viral load high. Because the viral load high means an enormous amount of cells infected in the reservoirs. If we reduce the viral load, we reduce the effect of the progression of the problems driven by the virus. But the presence of the reservoir full with virus still stands. And indeed, you see that those patients that started with a high viral load, achieved undetectability, still they tend to fail more than others. So this should help us in designing the de-intensification therapies strategies. Not necessarily those that have 1 million copies can be simplified probably, similar to those that have 30,000 copies at the beginning. And these are data that Domenico Di Carlo will present here at the meeting. Let me present just one slide that shows that if there is some resistance before simplification with some mutations that might affect drugs that we are using currently, that we used in the past, the risk of failure is far higher than those that do not have resistance at the time of simplification. So, and I think Domenico will present better in his oral presentation. Look at this case. This is a case that is quite interesting. This is a patient that was seropositive since January 1995, probably before that, but the diagnosis was made at that time. Was treated with a substantial amount of therapies. You see that all 3 drug classes. This was a situation at the time of a failure, mutations for an NRTI, but also for NRTI. Therapy interruption, typical at that time, then restarting with therapy at the time in which a viral load was more than 500,000. Was with this resistance. Clearly, this was lower than what we saw before, because the therapy interaction brought to the reversion of many mutations that are now in the reservoir. And the therapy was started with the therapy we may not start with today. That is Kaivexa and atazanavir, driven by the high viral load. But you see that the result was pretty good, despite that. But when simplification with tenofovir, FTC, and rilpivirine came, in about a few months, viral load came up. And this was the resistance testing at this time. This is, let's say, a few months after the rebound of the virus. What is interesting is that you see many mutations, including those for therapies that we didn't use yet, similar but not identical to the virus that we started with in 2006, but nearly identical to what we had in 2005 before therapy interruption. So in other words, if we don't care about the resistance that was present in the past, we might take the risk by giving the same therapy as it was before to let the previous virus come back and generate a failure. So probably this is something that we need to care a lot. So let me move to another point that is essentially when these mutations come. Because there is an idea today that at low viral load we have no problems with resistance. I slightly disagree on this aspect. What we see in clinical practice, and these are the data that Danilo published last year in Journal Antimicrobial Chemotherapy, that you see that the majority of the mutations are present in the intermediate bell of viral load. That makes a lot of sense because this is a typical figure of the appearance of resistance. But you see also that when we look at the low viral load, the below 1,000 copies, we still have a substantial amount of resistance. That is somewhat overlooked today, when someone says that below 1,000 copies, there is no risk at all of a failure with resistance. I think this is not true. And Richard is in the room and can judge better than me, explain better than me this article, that shows in a very simple way what is quite clear for all those that work in the field since a long time. That if you have a virus below 1,000 copies, that in my opinion is a failure, is not a control, is a failure. And in addition, there are mutations of resistance, and you keep going with the same therapy, this is the result. In other words, those that had less than 1,000 copies and the GSS score low have nearly 100% of the risk to fail the therapy in the 2 years after the diagnosis of resistance. While those that have a high GSS but still 1,000 copies fail far less, but still fail. So I think we need to reconsider the concept of low viral load in order for long-term therapy. If we want to keep the patient with the viral load control for 20 years and beyond, probably we need to care a lot about the low viral load. That is just the beginning of the story and not the end. The last thing that I want to discuss with you is the issue of transmitted drug resistance. I think that if we look at the data published in the literature, the apparent conclusion is that the transmission of drug resistance is flat, is the same everywhere, it doesn't change so much, blah, 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 etc., etc. I tried to look at the data a little bit more in depth, and I found some surprises that I want to share with you. The first is that, and this is again something that has been published pretty well in the last CROI, a substantial amount of resistance is in cluster. That, if you think about that, makes sense. So the issue, you remember the first slide that I showed with all the resistance at failure that is decreasing over time. If a patient that transmit the virus are those that have viral load detectable, this is obvious. If those have a viral load detectable only in a minor part have resistance, the transmission resistance must be lower. And instead, it's pretty similar. This happens essentially because there are clusters of resistance in which the resistance is not distributed equally among different patients. But there are some patients that can transfer more than others. And those that transfer pretty often may have resistant virus. And indeed, this is an article, again, by Richard Harrigan that shows the clusters of resistance occurring over the years. That is definitely increasing. And this is exactly what we saw as well in our paper that we published last year, in which we found two clusters, one of them in particular, no, excuse me, this one, in my clinical practice yesterday, I found the last, still there. No, I forgot to say. This cluster, yesterday, I celebrated the last that I saw. They became about 40 now, and yesterday I saw the last. So these are clusters of patients, quite well defined, that transmit resistant virus, that are still transmitting. So the question is whether the epidemiology resistance is well designed today, and whether we cared about trying to avoid that these patients that represent a sort of origin of new clusters are fully controlled, so identified, and whose virus is kept under full control. So you see that indeed it's not easy to say that the resistance is always the same. It seems, in my opinion, that it's changing, even though the final perception in terms of numbers is about the same. So these numbers is pretty similar, pretty flattened, is this algebraic sum of different results. Look at this. More or less, this represents data that say that the average resistance doesn't change so much. But you saw that it's not exactly as such, or is as such, but we needed to explore the differences and see where there is more resistance, where there is less. Look at this data that come again from our court. You see that the number of patients with the subtype B is increasing, the new diagnosis, and the number of Italians with the non-B is also increasing. This means that I cannot call anymore subtype B as autochthonous virus in Italy and all the others non-autochthonous. This virus, you see that is about 20% of the total patients of the new diagnosis, and even more, are diagnosed in Italians. So the virus has entered, and more interesting, you see that if I look only at subtype B, you see that the transmitted drug resistance tends to go down. But if I look instead at the transmitted drug resistance in non-B subtypes, you see that it tends to go up. So the algebraic sum says that the average drug resistance is the same, while it is in our cohort decreasing in B subtype and increasing in non-B subtype. So this means that here there is less control of the virus and more transmission of resistant virus. So epidemiologically speaking, caring about this group of patients is very important. And also it's clinically important because you remember the paper by Linda Whitkop on Lancet Infectious Diseases that showed that if you treat a patient resistant with an NRTI, you fail far more. Was it something for the past? No, it's still of the present. You see that this paper that was published last month shows that a patient with NRTI resistance treated with NRTI, even with the new generation, tend to fail far more than those treated with a boosted PI or even better with integrase inhibitor. So we need to consider that what we learned in the past has not part of the past. But what is for our future needs to be adjusted and updated on the basis of what we knew in the past and in the present. This is a typical patient. Let me show you a couple of patients, then we go toward the conclusion. This is a typical patient that diagnosed relatively long time ago, heavily treated, with this situation in May 2004, so 12 years ago, resistance, treatment with high genetic barrier, and we are pretty happy after 12 years of treatment. But we have also this patient that was diagnosed in 2010 during acute infection. And you see that this amount of virus, we tend to try to understand exactly which is the amount of virus, not only more than 10 millions, because 11 millions is different than 200 millions. And indeed, this was the viral load of this patient. This was probably the highest that I've ever seen. So, and the surprise is that he was not only acute, he was not only high viral load, but he was also fully resistant to non-nucleosides, and most probably also to nucleosides. Essentially, you see how many mutations are present there. So driven by this very complex situation, we decided to go for a very heavy therapy with 5 drugs. Someone may say that 5 drugs, there is no evidence that they work better than 3 drugs. I might agree for those patients that have a wild type. I'm not sure that it applies as well for those that have already resistant virus. But you see that with the 5 drugs, the therapy was perfect. The result was very good. The viral load dropped very quickly. CD4 went up. Then simplification started. I can anticipate that whatever you will see in this case is driven by good clinical practice. There are no major mistakes in theory. You see that 1 drug less, still very good. 1 drug less, so we return to a classical therapy with a substantial control, high genetic barrier, Truvada that more or less has some activity on the virus that we saw at the beginning. Then this patient never failed protease inhibitors, didn't have less than 200 CD4. So this is a patient that can be further simplified according to the rules to monotherapy. And this is the result. When genotype was done, you see the disaster. So we maintained the previous mutation or readapted the mutation, the previously present, and in addition, we destroyed the protease. So in other words, and the rules are fully accomplished in terms of rules, because the simplification to monotherapy can be given to those patients that have more than nadir of more than 200 CD4, never failed to protease inhibitors. So actually, that was a mistake. But formally, was not. So you see how it's important our work, our personalization of therapy in our patient. Should we expect the same for integrase inhibitors? Yes and no. Yes, because we are learning a lot about the changes that Anne-Marie and the co-workers are including in the chart that each of us use, and they are very well done. In terms of resistance at the beginning, however, the story can be different. Not so much resistance in these patients according to this paper at the beginning, though two publications showing resistance at baseline, but two patients in total. Then this presentation at CROI by Anna Genevieve together with Francesca with patients that have a minority species resistant to integrase inhibitors, still a minor number of patients, no evidence that this is clinically relevant. What is interesting is this patient that came to my attention 2 months ago, first diagnosis, and this is his situation. I was really surprised. I asked to check, recheck, and recheck whether this patient was really instead treated, and was not, was really naive to antivirals. So something is coming up, but not so much indeed. And the reason is this one. The number of patients that have resistance to integrase is very limited compared to the others. So the potential transmission of integrase resistance is limited by the fact, you remember the first slide, by the fact that the number of patients that have a failure today with integrase inhibitors is limited. So it is impossible to transmit heavily a virus resistant to integrase inhibitors, while the patients treated with integrase inhibitors tend to have a low amount of resistance. So I would expect that the increase of resistance in naive patients to integrase inhibitors there will be, but will be far more limited than we saw in the past for protease and reverse transcriptase. So the conclusion that I have is more to open the discussion rather than a real conclusion. First of all, we can say that in our clinical practice, we do not have a major problem for resistance in practice. But not because the problem has disappeared, but because we cared. We cared a lot. Indeed, we have today a resistance workshop where the room is filled. That means that the perception is that the issue is still there, even though, thanks to us, in general, is not a clinical major problem. However, it is still with us. Not a clinical problem, but still with us. If we don't care anymore, it will reappear. So the perception is that whatever treatment we give to our patients will be okay forever and ever. That might drive some surprise that I prefer not to see. For some geographic areas of Europe, however, this is still a relevant problem, and we discussed with Charles and with others, but particularly Charles is heavily involved in the issue of resistance in Eastern Europe, and we know that the resistance there is far more than what we have in Western Europe, as well as I said before, in Africa. So the next frontier for resistance may be different than those we saw in the past. When I say frontier, I mean the concepts, the clinical concepts that are behind the resistance. We need to have our patient fully control lifetime. So if we want to have so, we need to control the virus not only achieving undetectability, but also maintaining it and sparing future therapeutic options. This is absolutely crucial. In the frame in which new drugs are coming, and we need to reconsider the concept, for example, the NRTI backbone. In 25 years, the backbone was NRTI. It still will be in the future NRTI. Will we have a different backbone, perhaps an integrase used as a backbone? We do have the induction maintenance as an issue that will become more and more relevant in the future. Strong therapy at the beginning, simpler therapy in the future. Where should we position the new drugs? At the beginning or later? And finally, Today, we can achieve undetectable virus in a relatively easy way. You have seen that more than 90% achieve undetectability. However, we need to maintain it as long as possible. If we give a personalized therapy, if we tailor therapy on patient characteristics, we may probably achieve better results than just giving the normal therapy to everyone in our patients. Thank you.